Okay, now in the previous session we had discussed about a few of the diseases related to the oral cavity. The next is about the esophageal disorders. Again, as we have discussed already, we will be having more discussion on the most common disorders and relatively less discussion on the rare disorders. Now, among the commonest disorders of the esophagus, the esophagitis, and there too the peptic esophagitis or reflux esophagitis is the one of the most common clinical condition which we see. And very common, the clinical symptoms are, the most common symptoms are heartburn or dyspepsia, then water rash like excess salivation, regurgitation, and include other common symptoms include discomfort in the abdomen, nausea, bloating, or less common symptoms like dysphagia or oesophagia is less smell, foul smell in the abdomen, cough, even hoarseness, even hematemesis can also occur. And one of the troublesome clinical presentation would be when the patient presents with the chest pain, which is very difficult to distinguish from coronary artery disorders. Of course, we may have many clues to differentiate the coronary artery disorder from the chest pain produced due to the gastritis, but many times these clinical clues may not be enough. Many times you may have a real confusion with the coronary artery disorders, and many coronary artery disorders are misunderstood as esophagitis and vice versa, and complications have occurred clinically. And hence, when a patient presents with the chest pain in case of the esophagitis, you have to be very careful. If necessary, go for the investigations if you are not very much convinced. Now, coming to these issues in detail, like the gastroesophageal reflux, is a very common noun, and the common causes for this are whenever the patient presents with these symptoms, the commonest causes are the transient lower esophageal sphincter relaxation or esophageal sphincter relaxation. Now, esophageal sphincter relaxation has now become something like an epidemic. Majority of the people whom we see now compared to a few years earlier, now they have a more of esophageal relaxation, and this is due to the lack of exercise. Those who do not do regular exercises, they tend to develop the one of the very common complication of this is lack of exercise is the esophageal sphincter relaxation, which results in the next issue, the esophagitis and the complications. Sliding hiatal hernia. Now, sliding hiatal hernia can be a cause for the esophagitis, or also can be a result of the complication of the esophagitis. Low esophageal sphincter pressure or low esophageal sphincter relaxation. The differences are very minimal. The initial changes will be the esophageal sphincter relaxation, pressure will be reduced, then it results in the relaxation, and that's again due to the same issue of lack of exercise. Then acid pocket development due to poor mixing of acid with chyme in the proximal stomach. See, if the stomach shape is abnormal, particularly the fundus has become quite huge, in that condition too, it can result in a gastroesophageal reflux. And if the gastroesophageal junction has become more distensible, this again is very common in case of obesity. Patients with obesity, they tend to have that distended esophageal junction, or patients who have undergone thoracic surgery, they tend to develop the same issue. This also is another issue. And delayed gastric emptying. Now, gastric emptying is delayed due to either neurological factors or more commonly due to the food, the type of the food, particularly oily, fatty substances. They require to be in the stomach for a long duration, and if there is a delay in that emptying of the stomach, if the food is retained in the stomach for a longer duration, that increases the chances of gastroesophageal reflux as such. Of course, the clinical symptoms, again, as we have already discussed, its typical esophageal symptoms are heartburn, regurgitation, dysphagia. Abnormal reflux can cause atypical symptoms, and those atypical symptoms could be coughing, hoarseness, otitis media, non-cardiac chest pain. Of course, these are things which we have already discussed. Now, the other important issue, incidence of gastroesophageal reflux disorder, particularly due to the relaxed lower esophageal gastric junction, is increasing very rapidly in the past few years. And this increase is attributed to the lack of exercise, the mechanization of the life. And in India also, it's very frequent now. And what I have seen is almost every second or third patient where we put a gastroscopy in would have the gastroesophageal reflux degrees, different degrees. And hence a bit more about the detail of these gastroesophageal reflux esophagitis. Reflux esophagitis is classified as grade A to D by the Los Angeles classification. And the definition is when you have a reflux changes, the mucosal changes within 5 millimeters of the gastroesophageal junction, that's grade 1, and numbers of these striae are very few, less than 3, then it's grade 1. When it is more than 5 in number, but the distance is within 5 millimeters of the gastroesophageal junction, it's again grade B. In grade C, you will have more of these issues with this horizontal invasion of the mucosa. I'll show you some of the examples. And grade D is where there is a extensive scarification of the mucosa. Now, the same as you look at the gastroesophageal, this esophagoscopy, a grade A is there are very few erosions, one or a few erosions within 5 millimeters of the issue. Clinical symptoms would be usually they are related to the symptoms would be for short duration, usually within 1 month or so, and they are often limited to food. A patient would complain that only when he consumes certain specific variety of the food, the patient may have the esophagitis symptoms. Now, as you look at the esophageal you will see the one or two these areas of esophagitis, line-like areas of esophagitis, inflammation, and the number is usually less than 3 or 4, and the distance covered is not more than 5 millimeter. That's important. And the gastroesophageal junction may remain patent. You can see that patency, either relatively more relaxed or less relaxed, but this is how you will see in the gastroscopy. Now, these conditions, I would consider them as simply the dosha prakopa. The clinical symptoms of the dosha prakopa, like kosta toda sancharana amlika pipasa paridaha annadvesha hridayakledashta jayante vivya kriyakaraha. So, in these conditions, there is no need of prolonged treatment. Simple advice to the patient about the lifestyle and advice to the patient about the diet. Spicy food, vidahi aharas should be avoided. All that junk food should be avoided. And the patient has to do some relaxation exercises, regular exercises should be done, and try to reduce that weight gaining activities. And another usual advice would be have a gap between lying down and the food. The gap between the food and the sleep at night. This should be at least 1 hour. So after consumption of the food, immediately if the patient lies down, chances of these heartburn symptoms are more. And these generally do not require any treatment. But of course, we will not send any patient without medicine. So we will give Sudashekara Kamadiva for 1 or 2 weeks, and more than the medicine, it's about the diet and exercise which would be enough in such patients, and that's what we see in the low grade or the grade A type of esophagitis. If the patient takes the precautions of the food and the diet, it doesn't go into the next stage. Now, next stage is a grade B, where there would be more erosions, more than 1 or 2 erosions, and the erosion level would be more than 5 millimeters, and it usually seen like there could be cicatrical changes, mild constrictions also there, and the extent is more than 5 millimeters. That's what we call as the grade B. And in these conditions, the symptoms will be constant. The patient would have that symptoms of heartburn or maybe the regurgitation symptoms more commonly, and they will be constant, and many times it may not be related to the quality of food. Patient may say that even if he consumes milk, he may have that symptoms of burning sensation, and it may become constant, and many times it will be like patient also may have vomiting in the early morning hours, or at least nausea would be in the early morning hour. And this is exactly what I would consider as the आमाजीर्ण. आमे गुरुत्सः उत्क्लेदः शोथः गण्डाक्षिपुटयोः उद्गारश्च यथाभुक्तम् अभिदग्धः प्रवर्तते यथाभुक्तम् उद्गारः the irritations with the smell of the food which was consumed much earlier is one of the very classical clinical symptoms of the grade B as such. So in the endoscopy, you will see these features. Clinically, you will see the features like the more regular symptoms and that particular irritation symptoms persisting for a long duration. Then this is what we see in the Viruddhajian Lakshanas. विदग्धे भ्रम तृणमूर्छाः पित्ताच विविधाः रुजाः उद्गाराश्च सधूम अम्लः स्वेदो दाहश्च जायते. I would consider this grade B as the Vidagdha Ajirna. So grade A is simply Vata Pitta Prakopas, Dosha Prakopa, which do not require a specific treatment. It can subside if you take precautions to avoid the aggravation of the lesions. In Dosha Prakopavastha, Viruddha Ahara, if you consume the food or the activities which would neutralize the effects of the dosha, it's a self-limiting disorder. But grade B, it requires the treatment. And my prescription usually would be Sudhashekara, Kamaduga and Godanchari Patikara, considering this as Vidagdha Ajirna or Pitta Prakopajanya Ajirna. And if the patient takes precautions later on, the results are good. Treatment duration could be around 1 to 2 months. You will require a medicinal requirement for 2 months. But in all the conditions, exercise is one of the important issues. Now, in grade C erosions, this is another of the typical clinical problem, like where you will have erosions which are extending over mucosal folds much beyond 5 millimeters, and it can be like extensive, even up to the middle one third of the esophagus you may see, and the circumference of the esophagus seems to be reduced, or there could be even erosions around the area. The Manchester line seem to be extending, and you may see occasionally a soft-like conditions. This is grade C as such, and this is considered as a ajirna which is having more deeper involvement of the ajirna. That's katu ajirna vidahi amlaksharabdihi pittam mulpunam aklavayati hanti analam jalam taptamima analam. Like hot water also can extinguish the fire. Similarly, the Agni Manjavdaka. This is the typical description, and it's perfectly holding on to the typical clinical symptom of a food intolerance. In these patients, typically, patient would present with a symptom of food intolerance. He will not be able to consume food properly. The amount of the food consumed tend to be lesser, and patient will be afraid of consuming the food in these conditions. And many times the patient may also complain of food sticking at the lower end of the esophagus. That kind of a symptom would occur, and weight loss also can occur in such conditions. And the patient would have vomiting more frequently. The vomiting also would be more frequent in these conditions. So, Ajirnam Nilapitabhum Pitabhas Saryate Dhruvam Puti Amla Udgara Hritkantataha Rutitradritaha. So, I would consider this as the Pitta Ajirna or Pitta Udanamata, and in these conditions, the outcome would be poorer. My prescription in these conditions would be Aragavardhini or Agnitundi, depending upon the clinical symptoms of that food intolerance. If the food intolerance is quite huge, then Agnitundi is prescribed. If it is moderate, Aragavardhini and Sudhashekara, Bodhanti, Vipatkara, these are the usual prescriptions. Outcome would be poor. Patient has to continue the medicines, and it's a sort of vyapya. If the patient takes the medicines, the patient may be relieved, but if the patient withdraws the medicines, the symptoms may recur. Incidence of recurrence is quite high in these conditions, even though patient takes the precautions of diet and exercise. Of course, precautions of diet and exercise would be really useful. Now, grade 4 is when there would be huge erosions extending more than 3/4 of the circumference, or which we call as circular defects. Erosion. These also are now becoming more common, and in these conditions, the symptoms would be severe food intolerance. Patient would have a food intolerance, and the food is sticking to the thoracic area, in the feeling like a food getting stuck at the thoracic area is quite common. And patient may have a hematemesis. Many times, along with vomiting, there could be hematemesis. Incidence of these are relatively relatively less common, but it's increasing these days. And my prescription would be Argyrodini Kamaduga Godantavipatika, and outcome is extremely poor. Virachana with the Sukumara Ghata Snehapana also can be helpful in a good number of patients. So, in these patients, I may try that Virachana, and it may provide some satisfactory result, but the total net outcome would be poor in such conditions. So, important is in patients of esophagitis, instead of considering all the patients as the uniform conditions, if you can grade them and plan the treatment, the outcome would be better. Now, gastroesophageal reflux disorder, along with producing these different stages, the next of the another of the common complication is the Barrett esophagitis. Barrett esophagitis is another of the consequent complications of the esophageal reflux. The same issue when there is a relaxation of the food gastroesophageal junction, food getting refluxed out, and it produces a dysplasia in the esophageal mucosa, and that's what we call as the Barrett's esophagitis as such. Or the other complication could be it can result in hiatus hernia, that there could be shortening. Now, Barrett's esophagitis is a complication of esophagitis, where when you look at the esophagus with the gastroscope, you will see characteristically the mucosa being altered. See, normal mucosal folds are not present. Instead, the mucosal folds would be hyperemic, and there could be a baldness, or extreme conditions there could be ulcerations, even longitudinal ulcerations, or even ulcerations in the growth. Typical growth can occur. And Barrett's esophagitis is always considered as a possible precancerous condition. So, whenever there is a change of that sort, biopsy is needed. Now, from the endoscopy point of view, when you do the gastroscopy, if you find a gastroesophageal reflux beyond the grade 4, or if you find that there is a change in the typical appearance of the mucosa, instead of that typical mucosal folds, if there is a absence of the folds, looks like a somewhat rough surface, then biopsy is needed. Of course, when it results in a growth, visible growth, it's obviously tumor pathology, and all these are different stages. So, from the clinical point of view, the in Barrett's changes, uh, biopsy is a must. So, if biopsy is done, and then if it shows further changes like dysplasia of different degrees, the treatment would be of a different protocol. So, because it's a precancerous condition, the outcome would be extremely poor. I don't say that there is any standard protocol of the treatment in that condition from our point of view, but my prescription again would be Argyrodini Kamaduga, but I would advise the patient to have some other alternative choice of the treatment, like further evolution into the malignancy, and maybe chemotherapy, or depending upon the stage in which the patient is presented. So, anyway, that approach from the point of view of prevention or management of the malignancy is required. Many times it may not be possible to maintain the patient only with our treatment. But of course, it could be the other way. If the patient comes from some other hospital after having the diagnosis and is not ready to go on to the next level of the treatment, other way, we may give Kanchana or Kamadga, which is just a palliative treatment. I don't say that we can choose this. So, from the clinical point of view, this differentiation is important. So, that's about the peptic esophagitis or reflux esophagitis, one of the very common conditions. Now, the other variants of the esophagitis, again, patients may have the same clinical symptoms. Now, whether it's a peptic esophagitis or otherwise, may not be very easy to differentiate clinically. But if the patients are more of younger age, and have a history of something like a patient may have that esophagitis after some episode of fever or some other illness, and then the esophagitis symptoms occur. Dysphagia and vomiting are more common. Patient may even have abdominal pain. That's usually eosinophilic esophagitis. That's the next common condition. Now, I have put this sequence of these conditions based upon the incidence of the diseases which we see in our clinical practice, regular clinical practice. So, reflux esophagitis is the most common. The next common condition which we see is the eosinophilic esophagitis. Eosinophilic esophagitis is often presented as a symptom of esophagitis, like same symptoms like burning sensation, Vomiting may be more frequent. Patient may even have dysphagia, and usually it's seen in the younger age, more common in younger age, not necessarily younger age, and often it's accompanied or maybe produced after certain disease. Many times it could be attributed to the treatment of the diseases, or at times it could be attributed to a specific food. Patient may say that the substance specific food aggravates the symptoms. The identity of identification of the symptom in relation to a specific food is another characteristic history in case of eosinophilic esophagitis. When you look at through the esophagoscopy, the characteristic appearance would be you will see multiple islands of the mucosal atrophy. The mucosa would seem to be partially atrophied, not a uniform atrophy, and some islands, these areas, spots of that increased growth, and some areas of atrophy, linear areas of atrophy. These are very characteristic of eosinophilic esophagitis. Confirmation of the diagnosis can be done by biopsy, or when you do the peripheral leukocyte count, eosinophilic count also could be slightly higher in these conditions. I can treat these conditions with the Adnituni Surshekara Bhunimbadipata and Rakshasa. This is a variety of Amlapitta. I will be considering this as one variety of the Amlapitta, which could be either Vataja variety of the Amlapitta. Then the not very common, but next common condition which is infectious esophagitis. Infectious esophagitis could be very commonly Candida, pathology Candida induced esophagitis, or HSV induced, viral induced, or CMV induced esophagitis, viral infections. Now, whenever you have the infective esophagitis, candidiasis is presented with the colonies of thick slough material, whitish material, and lots of slough there. Whereas viral hepatitis, this esophagitis, either presents with some areas of necrosis or simply hyperemic changes, and based upon that, these symptoms should occur. In all the cases of infectious esophagitis, there has to be some underlying pathology, and it's always like they are secondary to some other conditions which can produce immunocompromisation. Patient may have diabetes-like conditions, or patient may have these HIV-like conditions. So underlying pathology needs to be investigated, and there is immunocompromised issue. So when you have this candida or the viral pathology, it's quite important to rule out the other underlying causes. The only other issue could be a patient who is on antibiotic therapy for long duration may develop candidiasis as a secondary infection. So I would not suggest any specific treatment for the infectious esophagitis now, but instead, if you have a case of infectious esophagitis, take the history in detail, examine further, and you may find some other clues, some other disease. It could be HIV, it could be diabetes mellitus, it could be some other disease, even autoimmune disorders can be the underlying causes. So that needs to be assessed, and the treatment would be always targeted to the primary conditions. There is no specific curative treatment for these esophagitis. If at all there is a need to give a symptomatic treatment, I would be preferring Gandhakarasayana, Kamaduga, and Godantyava Pratikara, the usual treatment for this, as a simple palliative treatment for the esophagitis. But again, I would repeat the same. Whenever you find this infective esophagitis, it's important that the underlying pathology has to be identified and ruled out. Then corrosive esophagitis is the next condition which we see. Of course, not very common. Corrosive esophagitis is due to consumption of corrosive substances, particularly alcohol. Now, these days it's common. Alcohol again, that alcohol without mixing with some other liquid like water or soda, and consuming that dry alcohol varieties, or chemicals. Many times it could be like homicidal, suicidal, or so on. Swallowing of chemicals can produce the corrosive esophagitis. And that history is important. Corrosive esophagitis is again classified into 4 grades, a standard grading of this corrosive esophagitis. Where initially the grade 1, where you have mild edema and hyperemia, which we see quite frequently. The ulcerations, superficial ulcerations, friable conditions, and blisters, or deep ulcerations These conditions, they require an immediate emergency treatment. So if at all a patient comes to you with this kind of a history where there is a deep ulceration or multiple ulcerations or with the extensive necrosis, that's a condition which requires an emergency treatment, either and this gastrostomy tube to for feeding, see, alternative pathway for feeding may be required in that condition, and the outcome would be very poor. So corrosive esophagitis, the condition number of cases which we see would be very less. So most of the times they may not come to Ayurvedic treatment as except that grade one patients may come to us, but grade beyond, grade 3 beyond, they may not come to our hospitals quite frequently. They require an emergency treatment. But from the clinical point of view, you have to identify these cases whenever they come to us. Then the next of the condition which we discuss would be the esophageal stricture. Now, esophageal strictures could occur due to either a mechanical injury done earlier, or it also can be a consequence of esophagitis. Chronic esophagitis can result in a stricture, or strictures produced due to growths, or strictures due to surgical interventions. Mechanical injury like a gastroscopy also can produce a stricture. This is important. Instrument induced strictures, injury and the strictures can occur. Of course, with the fiber optic flexible gastroscopes, the incidence of that has become lesser. But earlier, when we were using rigid endoscopes, the incidence was more common. Now, in the patients who have a stricture of esophageal conditions, the important symptom would be dysphagia. Patient would have a swallowing difficulty. And then when you look at the barium swallow X-ray or maybe the esophagoscope, you will see that there is a proximal dilatation. Proximal to the area of stricture, there is a dilatation, and the stricture has become narrow. And these strictures, they are mechanical pathologies, and they essentially require a surgical intervention. Treatment with the Sengstaken's tubes, where either dilatation with the Sengstaken's tube may be required, or they may require a surgical treatment as such. But with the strictures, one of the problem would be even if the dilatation is done, it may get recurrence. So such patients who have a tendency for the recurrence, dilatation usually we don't do in our setup. We send the patient to some other hospital. Now, the patients we get could be patients who have developed stricture, have undergone dilatation, but there is a possibility of recurrence, or there is a possibility of the esophagitis symptoms persisting. In these conditions, I would always prefer a Virechana with the Sukumaragasta Snehana, and this has shown some significant results. I don't say that strictures can be cured, but recurrence of the stricture constriction can be postponed, and the required frequency of dilatation can be reduced remarkably in case of the stricture pathologies. Then another of the condition is Mallory-Weiss syndrome. Now, Mallory-Weiss syndrome is a unique condition where there is an abnormal reflex of vomiting. See, in the normal reflex action of vomiting, when during the vomiting activity, the stomach would be constricted along with that high pressure of the abdominal wall, and simultaneously the esophagus and proximal esophageal, the pharyngoesophageal junction should open up so that the contents of the stomach would be expelled out. But if somehow this reflux is not coordinated fully, and as the abdominal pressure is increased, if the proximal pharyngoesophageal junction is not relaxed, instead it becomes constricted, there could be enormous pressure built up in the esophagus, which may produce a rupture. And that rupture is usually a linear, straight line like rupture seen under the gastroscopy. And this is what we call as a Mallory-Weiss syndrome. Incidence of the Mallory-Weiss syndrome is very often related to alcoholism. Persons who consume excess of alcohol, and after the consumption of the alcohol, when they develop vomiting, this complication is frequent. Now, this again could occur in many degrees. Most of the conditions which we see would be seen in or would be characteristic would be a simple superficial rupture. A deep rupture may not be common in majority of the conditions, but a deep rupture, complete injury, and leakage of the contents into the mediastinum can produce acute complication of mediastinitis. So we may categorize them into two categories. Patients who, and that's what we see usually would be patients who are alcoholic and after consumption of the alcohol and about of vomiting after the alcoholism, the patient may have a pain in the chest, acute pain in the chest, occasional hematemesis. Quantity of the fluid could be, this blood in the vomitus could be usually moderate, slight. Such conditions can be managed, and I would be considered these as a asadhya chhardi, or kashtasadhya chhardi. क्षीणस्य उपद्रवैः युक्ता शाश्वतपूयां सचन्द्रिकां छर्दिं प्रसक्तां कुशलः नारके च चिकित्सितम्. Sushruta has said that condition cannot be treated. But of course, Mallory syndrome of moderate degree can be treated, which doesn't require any immediate treatment or any rigorous treatment. All that what you have to do is give rest to the patient and ensure that the patient doesn't go into a shock-like conditions, and more irritation has to be avoided. So give some liquid diet which is not really irritant. Often milk diet is advised, and wait for 1 or 2 weeks with the main drugs like Sukshekar, Kamakar, Minitans, Triflagukul, so that it heals. So good number of Mallory-based conditions can heal if they are superficial. But if the wounds are deep and then there is a leakage of the content in, then the patient will go into shock and there will be severe mediastinitis conditions which require an emergency treatment, where the patient may require even a surgical intervention. You need to insert a rails tube there in such conditions and ensure that there is no more leakage. If the mediastinum has a high amount of fluid that requires a drainage of mediastinum is again a very complex process which we may not take up in our hospital setup. So that requires a more specialized approach, multidisciplinary approach. A thoracotomy may be needed, and even it can be fatal. So in case of Mallory-based disease conditions, the important is to decide like whether it can be managed with our conditions medically or not. Mild conditions can be managed medically if the lesion is related to the surface only and the usual criteria is the patient doesn't show signs of shock. Hemodynamic stability is there. Then in that condition we may manage. If the patient does, or if the hematemesis is not huge, then that conditions also can be managed. If the patient develops a hemodynamic instability, like shock-like symptoms, blood pressure being altered, if the patient shows toxic signs of mediastinitis, or if there is a huge hematemesis, it's better to go for multidisciplinary approach or refer the patient to higher centers as such. And incidence of Mallory disease is also now has become relatively more common because alcoholism has become a very prevalent as such. That's about one of the set of the disorders. Next set of the disorders which we discuss about the esophagus, relatively less common, are the motility disorders. Where there is an abnormality of the movement of the food in the esophagus as such. And it could be again achalasia, where there is a hypertrophy of the muscles, or simply spastic esophageal motility disorders, which could be either with a very specific diffuse esophageal spasm, or it's also called as nutcracker esophagus, or even it could be due to the extreme spasm or extreme tension of the lower esophageal sphincters. Or there is another non-specific condition where we cannot really make out the real causes as such. Then secondary to the diseases like scleroderma, diabetes, alcohol consumption, psychiatric disorders also can be presented as motility disorders. Now among them, achalasia is one of the conditions. Achalasia is produced due to spasm of the muscles initially. Later on there could be hypertrophy of the surrounding muscles, the circular muscles, and that hypertrophy would be again of different degrees. So usually these are classified. The achalasia is classified into the different degrees based upon the clinical presentation. So initially it could be just a functional stenosis. When you put in the gastroscopy, you feel that as the gastroscope is moved in, there would be a spasm. The esophagus goes into spasm, and you need to push more rigorously. The resistance you feel would be more. And esophagus otherwise may look normal, or the slight hypertrophy of the mucosal folds. Then that's what we call as grade A. In the grade B, there could be wrapping around the esophagus. Now, as the gastroscopy is pushed in, you will see a thick fold of the esophagus mucosa wrapping around the tube, and there will be bulging. That suggests of a very severe spasm of the muscles. So this is how you will see. Like if there is a abnormal constriction of the esophageal body, as you put the esophagoscopy through, there is a severe spasm of the whole of the esophagus, or mid-constrict of the esophagus also shows the evidence of a spasm, a ring-like appearance. That's what we call as the grade C acid. And the D is where there is a mucosal thickening and whitish changes. The whole mucosa has now become permanently thickened, and the mucosal, this lumen is really maybe widened, tendency have to widen. A very gross widening of the mucosa is grade when you find the residual liquid or food element in the esophagus, which has not proposed in. If it is remaining in, then it's a grade G. Now, D to G grades, that DEG grades, would be quite difficult to manage medically, and they require surgical intervention. A medical management is possible only in the first 2 degrees of achalasia, and achalasia is characterized by the presence of symptoms of dysphagia, and that characteristic dysphagia would be more for the liquids than the solids. And when you do the barium shallow X-ray, you'll see a pencil rod-like appearance about the defect with a smooth surface. Now, in these conditions, I would consider them as a pranavarta udana, and as I said, a medical management is possible only in the early grades, the first 3 grades. The next 2 3 grades, medical management is not possible, and in those conditions, my treatment usually is Snehana with Indukantagrata and Viretana, followed by Arogyavardhini, Kamadurga, Godanti, Vaikatikara. And some of the patients would show some good results, and if you have that discrimination of making out these stages, the outcome can be good. But in these conditions, the later 3 stages of the conditions, they require surgical intervention as such. Then another of the condition is diffuse esophageal spasm. It's usually psychological origin, where there could be the usual symptom of the patient would have a factor related to the stress, and whenever the patient attempts to swallow the food, there would be severe spasm. Patient would not be able to swallow the food at all. Again, the dysphagia would be more common for the liquids than the solids. And these symptoms may not be constant, where at times it could be more, at times it could be lesser. So that kind of a variable symptom of dysphagia is the characteristic presentation of the diffuse esophageal spasm. And most of the times there will be some psychological origin. The usual contemporary treatment, modern treatment given is nitrates given before the food. You swallow 1 tablet of nitrate and then take the food. Patient will be able to swallow the food better. This is the usual history, and this again doesn't resolve the issue completely, and patient would be always at distress. Now, when you take a barium shallow X-ray, that spasm is very clearly seen, and because of that multiple serration seen in the barium shallow X-ray, this is also called as nutcracker esophageal pathologies. And incidence of this also, though not very common, is increasing to a certain extent. And my prescription in these conditions would be Smith-Sagar because of the known psychological factors. Agni-Sundi and Kumari also considered this as a variety of Agni-Mandya. Or Viretana with the Snehana of Bindukantagrata is another of the treatment which I have tried in a few cases. Of course, number of cases which we have treated are relatively less, not so common as that of the other esophageal disorders, but this is one of the conditions where we can treat. And another of the treatment which I have tried in these conditions is Udavartahara Basti. Udavarta, it could be considered as one variety of Udavarta, and it also has given some results. Then another of the condition, though not very common, is the Schatzki Ring. Schatzki Ring is presents is again episode of dysphagia, as in case of the spasm. Here also it's a psychological the spasm which is short-lived. But in the difference between a diffuse spasm and Schatzki Ring is in the diffuse spasm, the whole of the esophagus is under spasm, whereas Schatzki Ring is temporary. only at one area there is a ring-like spasm present somewhere in the lower one-third of the esophagus. And this incidence is quite common and usually it's a short-lived. The symptoms would be very short duration. Patient would have an episode of dysphagia which is for a short duration, usually for not more than 1 week or so. Then again is relieved and there could be recurrence. And usually it doesn't recur for months or years. Some of the patients may have a dysphagia as such, and it's not that patient would have dysphagia constantly. So in a typical Schatzki ring conditions, which is again a non-specific pathology, where the exact real causes are not known, patient may have a this temporary episode of dysphagia, which often they may be attributed to the certain variety of the food or certain incidences in the life and so on. So history would be quite misleading many times. And of course, the symptom would be more when the patient takes the food in a hurried fashion. If the patient takes the food relaxedly, this symptom would not occur. And again, as in case of any other spasmodic pathology, the dysphagia is more frequent for the liquids than the solids. Solids can be swallowed better than the liquids. And such conditions would be and there again, when you do the esophagoscopy, you can see that one single ring-like appearance or barium shows again a ring-like constriction as such. Now, in these conditions, there is no need of any specific curative treatment, but usually what I would give is a Smithsagarasa Kamaduga for a short duration and the patient would have a relief and not a very critical condition, but it tends to occur somewhat frequently. Then the last part would be the esophageal tumors. Now, esophageal tumors are again very frequent now. Incidence is increasing, and the risk factors are well known. So, it's a condition where you have a very high number of incidences and the deaths also. And India is one of the areas where the zones where the incidence is significantly high. They're not very high. There are some other zones where you have more incidence than India. But India also is one of the country where you have more of these issues, and relatively known risk factors are smoking, alcohol, and high cholesterol level. These are known to be more well-known causes which are preventable. Now, another important issue is esophageal tumors. They come under preventable conditions of the tumors. And incidence again is more common in the old age, second half of the life in men more frequently, and the mortality also is quite high in such conditions. Now, in all these tumors, the one of the typical clinical symptom will be obstruction to the consumption of the food and more obstruction to the solid than the liquid. So, whenever a patient presents with a history of a dysphagia more for the solid than the liquids, it's either a stricture or it could be a tumor which requires more investigation. Whereas a spasm of the esophageal muscles, neuromuscular pathologies, they will present with the symptom of dysphagia for the liquids than the solids. Now, I will include all these conditions of different varieties of the tumors under Valaya, Balasa, Ekavrunda or Vrunda, where that Anna Marga Avarodha or obstruction to the flow of the food is considered as the clinical symptom. In case of Valaya, Sushil has mentioned the same, the Balaseva Ayatam Unatam Shopam Karoti Annagatim Nivarya. From Sarvasayeva Aprativaragiam Virginium Valayam Vasanti. Sushil has considered all these conditions as the Virginia are incurable. Galayat Shopam, Kurutek Prodo, Shreshmanila Rasa Jopavannam, Marmachilam Dustar Medan Alhu, Balasasundam Nipunaha Vikaram, or Ekavranda and Vrunda also is a similar issue where there is a Shotha which can produce a obstruction to the flow of the fluid, and it is a apaki, doesn't separate, non-separative swellings in the annamarga are these conditions. Now, the varieties of the esophageal tumors, again, I will not go into much of the details here because the conditions which we do not really treat in large number, but diagnosis is important. The important is the tumors of the esophagus, they could be primarily either squamous carcinoma or adenocarcinomas. Squamous carcinomas are more common in the proximal esophageal gastric junction. So most frequent locations of the esophageal tumors are at the stricture or these constrictors of the esophagus. Constrictors are proximal constrictor, middle constrictor, and the lower constrictor. The proximal constrictor is at the pharyngoesophageal junction, and most of the times it could be squamous cell carcinoma. And in that condition, when you start with the esophagoscopy, the moment you cross the pharynx, you will be able to see the tumors with the elevation, roughness of the mucosal surface or even projectile lesions seen over the area. And usually they would have a smooth surface, lesion would be having smooth surface. Middle constricted esophageal tumors also are less common, and they are usually of adenocarcinoma variety. The more frequent are the lower esophageal tumors, which are essentially adenocarcinomas, and they tend to have necrosis of the tissue, and they are more frequent. The tumors may be ulcerative, where you may have the ulcerative, or annular, where they could be circular as such, or there could be even pedunculated as such. The appearance could be of different varieties, either as a small pedicles at some areas, or it could be annular, where it could be ring-like projection involving whole of the circumference, or ulcerative. These are the typical presentations as such. So that's about the abnormality, and of course grading of early staging of these changes of the adenocarcinoma are usually graded based upon their pattern of the distribution. When you see these polyp-like conditions with the rough surface, and if you plot them, the shape of these lesions, they are usually what we call as a geographical shape, which may look like some areas of your map, zones of map. And whenever you find these kinds of the appearance in the mucosa, you may have identified the tumors at an early stage. So the most important point would be, which you can contribute to the patient, would be an early diagnosis of the tumors. So when it has a full-fledged like ulcerative lesions or annular lesions, the diagnosis is easy. But when you see the mucosal changes with slight hypertrophy or polyp-like appearances, and if these changes have a appearance of what we call as the geographical shape, you are sure that it could be malignant, and biopsy at that condition is a must. And most of the times, these kinds of biopsies will be positive. So we may get a credit of making the diagnosis early, though the later the treatment is something later issue. Now, esophageal tumors also can have extraesophageal symptoms. Patients who have a dermal keratosis, thickening of the keratin tissue of the palmar or plantar surface, can be one of the, not that every patient who have keratosis is esophageal tumor, but patients of carcinoma esophagus can present with these extra esophageal symptoms. So a patient presented with the dermal keratosis, if the patient has some symptom, even some clue about the possibility of esophageal involvement, go for the investigation, and there is a possibility of having a positive diagnosis. Grading of the tumors would be based upon involvement of the mucosal layers. When it is limited to the mucosa only, is a T1, and T2 is when it has involved the muscular layer. T3 is when the serosal layer is affected, and the survival period in case of these would be like in grade 1 survival period is 5-year survival period is 80%, and in grade 4 survival 5-year survival period is almost to 0. So the important would be an early diagnosis. As far as the treatment is concerned, I don't say that there is any curative possible treatment from our side of point of view, and I would always prefer to refer the patient to some other hospital, either for radiotherapy or maybe the surgical treatment. One of the basic, very difficult issue in this management would be, as the patient is not able to swallow, and all other medicines have to be given by the oral route, virtually we will be hand-tied, and hence even attempting to go for a palliative treatment would be quite difficult. With this, we will end up with the esophageal disorders. If there are any questions, I will try to answer, and then from next session onwards, we will go to the stomach disorders and further issues. If there is one question, what you give as samsarjana krama after relation? See, samsarjana krama, there is no question of giving any medicines. Is as good as the manda peya vilepi. For the first 2 days, it's only the liquid portion, ganji, tili, that's the manda. Then gradually peya and vilepi. Usually by 6 or 7 days, the samsarjana krama would be over, and the patient would have the normal diet. That's how it's planned. And then during samsarjana krama of any of the vilachana, whatever the prescriptions are being given, medical prescriptions, I would continue those medical prescriptions. That's it. Right. If there are any more questions, right. So we'll wind up today. Next, we'll continue in the next session about the gastric disorders.